Welcome to our monthly Home Care Alliance of Massachusetts Regulatory Roundup. Colleen has graciously, agreed to do this on a monthly basis to everyone so that we can meet everyone's questions and needs as a monthly basis. And you could tell more, Colleen, things change kind of rapidly around here. So I'm going to pass it along as I play whack-a-mole. Please make sure your microphones are on mute.
Thank you, Cynthia. Hi, everyone. Welcome to the, I guess it's the inaugural Regulatory Roundup. I put AKA Colleen's Corner, just as a funny note that when I first started the Home Care Alliance, Pat Kelleher wanted me to have like a news article called Colleen's Corner. I'm like, I can't do that. So I'm going to call this Colleen's Corner instead. So hopefully this will work out for everyone. Oh my goodness, hold on. There it is. So I'm going to start with, I try to group this into federal regulations, state, and then hospice. And then at the end, I have some educational opportunities and events that are coming up. So I just wanted to, I think I mentioned this in a meeting before, but the HHS and the Office of Civil Rights have recently, it was early January, proposed a HIPAA security rule. And it talks about cybersecurity. The reason they did it was because of all the problems with cybersecurity and hospitals and healthcare. And so they're looking to advance and enhance the encryption, the multifactorial authorization, vulnerability screening. Then there's a risk analysis, so it's comprehensive documentation and tech inventory reviews. I know you have to do risk analysis, but I don't know what's different from this proposed rule than what we do now. And I'm certainly not an expert, and I can't tell you how many pages this rule was. Then it talks about annual compliance and incident response. So as soon as this came out, I contacted the, actually we're a member of the Mass Cyber Center, and I sent them the rule. They didn't know about it. And so I asked them to, assess it, analyze it, and then give us feedback. So just recently, they told me that they did. And there's a meeting tomorrow that actually Harrison Collins, our legislative person, is going to be on. I have something the exact same time. So we'll keep you posted. Hopefully, the reason I'm looking at this, I just don't want it to be an administrative burden on folks. And, this is the time to make comments. So if any, and I actually sent this to our MIS listserv. So if you can go back to your information systems person, if they took a look, ask them, is this okay? We're already doing most of it. It's not going to be a burden. That would be great. And then let me know it's fine or if this is an issue. So any information we can get, it'd be great because we're not sure how it will affect you. I get a couple of questions about this. A few agencies didn't realize that telehealth actually was extended, and it has been through the American Relief Act. The person asked me where it was, came from. And it extends it through for home health and hospice through March 31st. That's as far as we know. Hopefully we'll hear something soon that it's going to be permanent. I haven't heard anything through the grapevine or anything, so I'm not sure. And also Mass Health Guidance aligns directly with the federal regulation as well. So the new COP, it came out with the final rule last year, and it's acceptance of service. It's a policy. The new COP number, if you're interested, is 484.105I. And basically, you have to develop and maintain a policy, and I put for every referral. So I think a lot of you already had an admission policy. You might just had to have add to it. At the beginning of the year, I developed a little template, but as my little disclaimer was, I didn't have interpretive guidelines and, just use it as maybe a template, but, delve into it more. And as I'm reading the policy, someone asked me, well, we have the policy, we all set. No, not really. You have to make this operational. So maybe doing something with every referral. We can talk about that in a minute, but I just want to make sure as part of your policy, you do have that, you will publicly have available your service details. So basically, I think what this is that if on your website, if you didn't have speech pathology, that would be on your website. Or if you knew your speech pathologist was going on a leave of absence because you don't have that service at all, that would go on the website. So if the person went on a medical leave and they were going to be gone for 2 months, you would put on your website, speech language pathology will be available in May or, whatever. So that's what the update. People were asking me, well, how often? We have to do this every week with staffing. No, this is, as I'm reading this is your services that you have permanently. So if you don't have home health aide service, you never give them, that has to be on your website. If you don't give MSW services, that would have to be on your website. And it does say in the regulation, you have to update annually, or then when a service is unavailable. So that's where that 3 to 6 months come in. If it's a week or 2 or something like that, I don't think they expect that. But you'd have to have something internally to tell you or tell your intake staff if you had short leave. So that's part of the operational. If a surveyor said to you, well, this speech pathologist is off for 2 months, how does your intake person know? So operationally, as long as you have something that they would look at, I have a feeling they'll be looking at this. You also, if you could you could link to Care Compare to say what your services are, but you have to make sure they're accurate. And I don't know how difficult that is to do. So just a few key considerations to think about when you are doing this operationally for intake. Maybe they have a checklist or something, or I don't know, something on the wall. What are the patient's anticipated needs? So what I mean by that is, well, that intake said we never can take a TID or we never can take a BID. Or if you look at the referral and there's no caregiver and you realize, this patient is beyond your scope because you don't have home health aide, that's what I mean by the patient's needs, or a diagnosis that, maybe you're not familiar with or whatnot. So then they want you to look at your agency caseload and case mix. So the number of patients that you have per clinician, your average, the complexity of it, and then your staffing level. So again, it's kind of with that caseload, your available disciplines. And then finally, they want you to look at staff skills and competency. So, if you don't have, or if you have WOCN or something comes in, or psych nursing and you don't have psych nursing, or you have no IV person, you would need to keep that in mind for your intake people so they know. And they're always up to date when they take in the referral. That's what CMS is. When I was looking through the final rule, I don't want to say they hopped on it, but I can't think of a better word right now. Consistently, you're taking it, home health agencies take a referral and patients are waiting, that type of thing. So they want to make sure that your intake staff realizes what your services availability are. So I just put this, maybe for referral intake procedure. I actually got this information from the Alliance, the new National Alliance, which was National Association of Home Care, and the hospice. Association. So they had this intake referral procedure. So this is not my work, it's Mary's, Mary Carr's. Just wanted to pass it on to you, though I thought it was good. So maybe you have, or you instruct your intake staff to talk about eligibility assessments. Is it the appropriate care for when you get the referral? Can you do this? Then your evaluation criteria. I kind of said this on the other slide, what are those patients' needs, the case mix, the skills, what staff. So if you have this or your intake staff readily knows this, and you can show a surveyor that you're living by this, that it's not just a policy in a bookshelf. And then the other thing is, though, to follow up, I believe this is what Mary was thinking. So, okay, that comes there then, but look at your staff assignments. What is your practitioner? Can they develop these care plans? Are you going to coordinate with your team regarding the patients? So I thought that was good information to pass along. Just so you know, the acceptance of service policy, as I said already, there's no interpretive guideline. However, when you go to the final rule and you go into the section, it's like the preamble. So this is the comment and this is CMS's response. That CMS response is part of the regulation. So when I was reading it, it does say that this has to be operational. So I think it might behoove you to just look at the preamble for that section. And again, what is in the response from CMS is what the surveyors will look at. Mary told me that the state surveyors have been told to pay attention to what's in that preamble of this final rule until the interpretive guidelines come out. And I wanted to tell you about some upcoming education we are having. It's called COPs, Acceptance of Service Policy, What to Do. I gotta look at it myself. It's March 26th from 1 p.m. to 2:30. And I believe it's recorded, but I'm not 100% sure. Let me see. And if you have questions, you can put them in the chat. And I'll try to pay attention to them as I go along. Just an Oasis E update. The reason I put this on here, I know you all know that there's a privacy, you give the patient a privacy notice and either attachment A, and now you no longer need to give attachment C. So for all payers now, you're giving them privacy notice and attachment A. And right now it's voluntary to be doing Oasis on all of the payers. But I put this on here. Are you ready? When some agencies were first starting this up, and some agencies wanted to start it already, like this is the new year, they didn't want to confuse the staff. They had some problems with their computer system. So that's why you might want to start a couple of weeks early or a month early. I don't know what your caseload is, but I'm thinking more of it's your submission or what your computer does or how you monitor that. So I just wanted to bring that up. And as we all know, this excludes under 18 years of age, maternity, and personal care only services. So some deadlines, OSHA deadlines for reporting illness or injury of your employees from last year. The deadline's March 2nd. Hopefully none of you have anything to report, but I'm sending this as a reminder. This does include any workplace injury, needle sticks. When I saw that, that's why I put it on here so you didn't miss it. And there's more information on the OSHA. There's a lot of good information like what to do and when should you do it and all of that. So the home health quality reporting program, again, you probably do know this, but the transfer of health information for patient and provider and the discharge functional score are new. And the April refresh, there will be the removal of the 60-day acute hospital and emergency department use. I wanted to bring this to your attention because I was curious when this first happened. I think it was the end of January. I received a notice because I had signed up for the Open Door Forum and said it was canceled. And I thought, well, that might not be unusual. But then on January 21st, the federal health agencies ordered a halt to the external communications, meaning, so the U.S. Department of Health and Human Services put a moratorium on it across all the agencies, including CMS and CDC. So they can't give external guidance right now, no notices, forum discussions until there's a presidential appointee. And I sent this, Cynthia put in the chat, by the way, the link to this. I apologize. I got it to her too late for you to get it. So the memo is here if you want to take a look at it. And that was sent by the acting head of HHS, Dr. Dorothy Fink. So wanted to let you know if you're looking for your open door forums, they've been canceled. I just want to check this chat. Do I have an update? I have a question about this. Do I have an update from Mass Health regarding EVV, who it applies to, and when the mandatory date for using? Yes. So that's a big discussion, but basically you should be using this January 31st. You should already be using it. You should be testing it with all your patients. You have to use it when your home health aide, your skilled services, you know, all your disciplines are involved with this. Okay. Oops. So I finished with the federal regulations. So I wanted to have you updated with state regulations, and I'm going to start with the Mass Health first. So Mass Health updated, and it's minimal update to a member connection form, and they call it MCF. And it's available and updated. That's the link. But I've been getting a lot of questions with it. And the reason I'm getting a lot of questions is because Mass Health is out auditing agencies, and they're looking for this form. And you want to make sure you have the form in the chart for the patients that you need it for, and then it's correct. So I think that's why I've been getting so many questions. So basically, all that Mass Health did was reformat the document. And that at the end here, it used to say, so for members, you give this to, let me stop for a second. You give this to your members who are over 65 that you feel need ASAP services, or when you're in there, or if, when it's time you're in there and it's within 15 days of discharge, you would look at it again. And then if they declined, they didn't want it, you would fill the form out and say that they declined, or you would note it in the chart that they declined. You have to have notification about this, that you even did it. So before it said, which was really confusing, and I pointed it out to them and I asked them to fix it, it said members 65 plus needing ASAP services and within 15 days of discharge. So you had to do it twice. You know, if you already did it, they're already involved. What are you doing in 15 days of discharge? So they did or for me. And they really didn't change any other wording. You also have to do it for prior authorization of ADL supports only for members 21 and plus, and who are also enrolled in the HCBS waiver program. Any questions? Okay.
Oh, I just have a quick question, Colleen.
Yes.
Is this just for straight Mass Health or other Medicaid products that we have to use this for?
Oh, that's a good question.
Is this the EVV?
No, this is
Oh.
Mass Health. This is the,
Sorry.
let me go back. I don't know how to go back.
I'm sorry, somebody interrupted me, so I missed part of it.
This one, this is the member connection form.
Oh,
So this is for your Mass Health patients. I don't think it's a requirement. I'm gonna look it up though. Let me write myself a note and I'll find out and I'll get back to the group. I would say no. Mass Health, the Mass Health managed plans have their own documents. But I'll check it out. I just want to write it down so I don't forget.
Yeah.
Now for EVV, that question came up. EVV is also for the Mass Health plans. So if it's a Mass Health, it's been managed Mass Health, you also have to do EVV for those products as well. Let me see what else is in the chat before I move on. Yes, there is notice from Mass Health at EVV showing the date of January 31st. I will share it with, who's this? Yes, you might want to email me afterwards, and you're going to have to get up and running agencies who haven't got up and running yet, because eventually, and they actually sent another notice out first week in February, like, this is a deadline and we don't want you to get sanctioned. So I will send that notice to you as well. Okay. Does this apply to maternal child health visits? I'm thinking. I know it doesn't apply to CSN, but maternal and child health, I would think so. I didn't see I mean, you're still billing regular Mass Health, and I don't know of any. I'll check it out. I think it applies to maternal child health, but I'm not.
I'm not asking about EVV. I'm asking you about the member connection forms.
Oh, I'm sorry.
Sorry, I didn't clarify.
No. It's only for over 21 with ADL supports and members who are 60 plus. Yeah, no pediatrics need that form. Yeah. So someone's asked me, I found an article stating that EVV is for dual eligible patients, even when Medicare is the primary payer. Can you confirm? Yes, I believe that is true. So many different things with EVV. I don't know EVV, like I know other regulations. Jake usually helps me with EVV, but I will check that out. I've seen that before. Because there's a possibility you could bill Mass Health for it. But I'll check. I'm almost positive I read dually eligible.
Colleen, EVV,
Yes.
yes, so if they're a managed Medicaid, you have to submit, and in order for that information to be accessible, you have to have the Mass Health number, so it may be like Commonwealth Health or something that dual eligible, but you still have to submit the EVV data over. And you
Okay.
need their Medicaid or their Mass Health number in order for it to not reject back to you.
Oh, wow.
We went live early. That was kind of a hard lesson learned on our behalf, because in all the trainings and webinars and informational, we never heard them say that you needed to have that Mass Health number up front. So we did a lot of scurrying to get that in play. So those
Wow.
did the first round.
Wow. I'm surprised I didn't hear that. And we actually asked them for another town hall. I was on a stakeholder call. Oh my gosh, it was yesterday, Tuesday. And they mentioned EVV at the last minute, and I actually had to jump off the call, but we did ask them if they were going to have a town hall for, people who have these questions now.
Yeah.
Oh, Amy Richards shared the same issue, needing the number up front. So for the dually eligible, though, I think in this, Kate is asking for Medicare. I guess she's thinking she's never going to bill Medicaid. Like, she's positive it's Medicare and they're homebound, and it's a good question. I'm kind of thinking you still have to do it, but I have that as well.
Yeah, I'm not sure. Because we're integrated, so we have an interface,
Yeah.
and I don't recall any kickbacks on a Medicare. I mean, well, I guess we'd have the Medicaid patients, not the Mass Health number in there anyway if they were dual. So it may have just passed through. I can try and look in reporting to see if we have any that may have gone through.
Oh, that would be good.
The only service area I know that is not required is hospice. So
Yeah.
hospice is not EVV required.
Yeah. And continuous skilled nursing, CSN, it's not EVV either.
Yeah.
Thank you, Kelly. Oh, no. Hold on. Oops, multifactorial. You might have already done this, but I just wanted to bring it out because, there's so much information. People miss things. I miss, somebody might ask me something. I'll say, oh my gosh, I didn't even hear about it. So this multifactorial authentication requirement is through Mass Health. Again, it's effective February 23rd, so you got another week or so. And you have to designate one primary and one backup user. And the users must have unique emails and logins. They can't be that one person being the same. They have to be unique emails. So the MMIS and the POSC, those are Mass Health sites where you look in to find eligibility. They've been around as long as I can remember. Well, the POSC anyway, it used to be archaic back in the day. So Mass Health is moving to AWS, Amazon Web Services, and there's been a bit of a delay. So they told us this on, I think I might have even sent an email blast. I'm not sure, but they told us this in the stakeholder meeting yesterday. The new date is March 14th. There should be no impact on functionality, they said. But what I think this is different, maybe due to the dates. It says to check your Mass Health eligibility before Friday, March 14th at 6 p.m. And then you can't check it again. I don't know if people check it on the weekends, but you can't check it again until Monday, March 17th at 7 a.m. Well, agencies are open. They probably would try to check them, but you're unable. So you'd have to check them first thing in the morning on March 17th. And then the financial cycle moved to March 12th, so earlier, instead of Friday, March 14th. So that's a change. And you can start submitting claims by Monday, March 12th at 3 p.m. If it says submit claims by Monday, March 12th, if you usually submit on Thursday and Friday. So that must be that transition day that they're going to have. So that was the guidance that we were given at yesterday's Mass Health stakeholders meeting. And I'm just going to jump up to the chat while I'm still on this page. Confirming not hospice for EVV, correct. Which service is the MFA required for? LTSS or virtual gateway? I do not know the answer to that. Kelly, do you?
We're interfaced, but my gut's saying it's the virtual gateway. But I don't, not 100% sure on that.
Colleen,
Yes.
that last sentence on the MMIS and the POSC migration,
Yeah.
it says Monday, March 12th. March 12th is a Wednesday.
Oh, you know what? You're right. I'm going to tell you I'm lazy. I copied and pasted from the actual document that Mass Health sent me, and I didn't check it, and they made that error in the stakeholders meeting.
Yeah,
So
they
I
had that,
repeated the error.
yeah, they had it wrong yesterday too, yeah.
I'm sorry, that's me cutting and pasting.
No worries, just want to make sure everybody's clear.
Yes, thank you for pointing that out. And Kim is telling us it's the virtual gateway. Thank you, Kim. Okay, moving on. So the Massachusetts, this, I don't know how many agencies are on this call who have CSN, but this is for all members, so I'm going to mention it. So to be eligible to be a CSN provider, you could be Medicare certified, or you could have a home care, different certification through ACHC. And then there's another third way. So there's 3 different ways you can be eligible to be a CSN provider. And somehow CHAP, the Community Health Accreditation Partner, somehow they were left out of that regulation. And so we were meeting with Mass Health all of the end of the end of the quarter for 2024, and realized this was an oversight, but it had to be changed and all of that. So there's no other accreditation pathway, or there's no other change in the document except they've added CHAP. And if you want to refer to the CSN Agency Bulletin 23, if you provide those services, that will give you more information. Just so you know, in case you see this, the EOEA, so the Executive Office of Elder Affairs, who we work with a lot, had a new name change. Their Executive Office of Aging and Independence, AGE. And it was going to be EOAI, but they didn't like the AI because of, with AI. So they just made it AGE. Easier to say, I guess. So there has been a change in the services that I just wanted to point out to folks. There is to their eligibility programs for the ASAPs. So the AGE put in a new intake management program because of the Massachusetts budget constraints. So they had to adjust their criteria and their service authorizations all behind the scenes. And how they did it is they've prioritized the high need individuals. They're going to have the priority. And then the patients who have lower needs are going to be on a waiting list or denied entry altogether. So, there's a lot to consider with that. We're actually advocating for some legislative solutions to this. Jake and Harrison are working on it. So if you have any feedback about this, they welcome your comments. I think you might all know about this, but I had a question about it recently, so I thought I would bring it up. That's how I make my agenda, by the way, how many questions I get. So the Massachusetts is going to join the Nurse Licensure Compact, the NLC. So legislation was passed in November. Yes, we're going to do it. But the Board of Nursing sent out a notice that it's going to take at least a year to implement it. And the reasons why, I thought I'd tell you why, because of the new legislation, they have to do background checks, they have to do regulatory and IT updates to the systems. There's a new multi-state licensure application process they have to fix. So that's going to take time. And this is the question someone said, could out-of-state nurses practice in Mass? No, not now, not yet. We have to wait until we get noticed. And again, I think it's going to take a whole year to do that. Penny wise and pound foolish, I agree. Okay. So the Oh, I'm sorry, I can't see. Okay. The issues with ICE guidance for healthcare providers. So the Attorney General sent this guidance out. I was going to say noticed guidance out, which is the link is right there to help healthcare providers with immigration enforcement and what access to care could be affected in assisted programs. And I guess there was a lot of issues with it already in the state. So some key takeaways in that document: that healthcare is to remain accessible regardless of immigration status. The providers are not required to ask for immigration status. And hospitals and clinics remain protected spaces. So I am no expert on this whatsoever. I'm really just passing information on. I probably couldn't even answer a question, to be honest. These some resources that you can have, but we have been getting a lot of questions. So the Alliance is working with, I don't know what speaker it is or organization. It might actually be the MIRA Coalition. And they're planning a briefing on ISIS-related procedures to help you in case something happened. So I wanted to pass that on to you. Okay, I finished with the state. So hospice, although there is another state one, it's the next slide. So it's about vaccines. So people don't hang up yet if you want to know about vaccines, COVID vaccines and flu. So Maverick is the Massachusetts Vital Records Information Collaborative. And this is a big deal, of course, to agencies who pronounce death pronouncements. I've been talking to you this for quite a while. They were supposed to go live like I think it was in the summer and then in the fall and then like January, and it's been postponed again. And off the top of my head, I remembered it being like a date in March, like March 17th or something. But when I looked on the website, it just says early 2025. So just keeping you posted. And as you know, this replaces the Vital Information Partner System that you presently use to register deaths. The hospice assessment tool is going to be implemented in October 1st. And only hope data will be accepted for the patients admitted or discharged on or after October 1st. There will be more information. Cynthia is working on I think it's couple of hours training in the springtime, late springtime. I've been told it's a good idea to, get familiar with this in advance, not just right before. Someone is commenting on the ISIS. Yes, if you could email me that. I don't want to lose this chat. And I'm not sure I don't want to forget to retrieve it. So if you could email me what your thoughts are, I'd appreciate it. Okay. Oops. So this came across my desk. Actually, I was on vacation last week, so I guess this is when it came out. Hospice, COVID ID, and influenza vaccine requirements. There was a transmittal from DPH to a lot of providers. There was like a big one. And hospice is included. And as a condition of licensure, and this is specifically for hospice, that's the licensure section if you want to look it up. Hospice programs are required to ensure that all your healthcare providers are vaccinated annual with the influenza vaccine and are up to date with vaccine doses for COVID-19 as recommended by the CDC, unless the individual is exempt from vaccines. So down below is the actual transmittal. So I put that link there so you can look at it. I want to remind folks, though, I've got a lot of questions with this. Don't forget the exemptions are religious, medical, and refusal. You can refuse. I don't want it. I don't want it. If they refuse, this is the documentation you need. All right. You have to document, and an agency actually got cited on this a couple of years ago. They didn't have proof that they educated the staff about the risks and benefits of the vaccines. So if you wanted to have a form letter or something, informational, I should say, that these are the risks and benefits, and the person signs it, or even you just say you gave it to them and then they attest, you have an exemption statement that includes their signature certifying that they had that, you made it. A lot of agencies call me and say, oh my gosh, the COVID, we didn't realize it was mandatory. This regulation is mandatory, but people can refuse now. We weren't allowed to refuse back then. So I think that's where the confusion is. And this is the exact same as last year. They just sent it out again. Like nothing's changed. And for home health, I got one question about that. We're not licensed in the state for home health. However, DPH surveys us, and we have to protect our employees, and we have to protect our clients, and we have to do best practices, which this is one. So keep that in mind. And of course, and when you look at the regulation, I feel like I'm preaching to the choir, but you also have to do mitigation, right? Like they can't see a patient that has COVID, you have to give them PPE and all of that. All the stuff that we used to do, just don't, just keep that in mind. These are just a couple of updates. We have the aggregate cap reports are due on February 28th, right near my birthday. And the cap value for last year is over 33,000. And you have to submit that to the CMS Identity Management System IDM. I just need a sip of water, excuse me. Care Compare Refresh update is February, and then the upcoming one is March of 2025. Your preview reports for March 2025 are coming out this month, if they haven't already. I don't think they have. I probably should have put this up with Mass Health when I did that section of Mass Health, but this is Mass Health for hospices. They just recently, I would say within the past month, updated their hospice billing guide, and they're calling it billing tips. And there is new guidance on that. And there's the link, by the way, at the bottom. There's new guidance on the hospice room and board calculations, how you calculate that, and medical leave of absence rates. I remember the agency I worked in, for some reason, we always had a problem with that board and room. So I just wanted to pass that information on and that document if you need it. I'm just going to scoot up to the chat. Oh, someone already did work for me. I found an article stating that oh no, I didn't. That's not new. That's not the new one. We had the same issue, needing the numbers up, confirming no hospice. Which sir? Oh, they did that one too. Virtual gaming. Did that one too. Did they define, yes, did they define COVID update? They said whatever the CDC is. So whatever, I don't know what the CDC is saying. I didn't look at it. Sorry about that. I was going to send that link too. I forgot, sorry. So that's it for my regulatory update. We can have a discussion at the end, but I want to pass a few things on that I thought would be interest to you and your agencies and your staff. This was recommended to me. It's free training, and it's for the staff on the road. It's offered by Nevin and it talks about emergency planning and procedures and caregiver and agency responsibilities. This is the link to it. Learning pathways, discover a way to train caregivers and reduce cost. I did not look at it. I actually went to it and said, oh, I'll do it. And I never had time. So I truly don't know, but I'm just passing it on. So don't shoot the messenger. No, if it's not good, please let me know. We have a lot on our community calendar, and I hope you look at it periodically. Cynthia puts a lot of education. We've been working on it, like what needs that agencies have. So there is a lot of education. But I wanted to point out a couple of things. These are more events or meetings. We have a town hall tomorrow between 12 and 1. And I believe you do have to sign up for this, Jake. Yeah, I'm pretty sure you do, so we know who's on the call. And we're going to talk about the state of the workforce. And Harrison will be on that as well. So that will be an important meeting for folks to go to. I wanted to let you know, if you didn't know, if anyone, I hope there's some new members. I know we have a few new members, but or if you're new agency leadership, you're new to leadership, you're not a new agency, you're new to leadership. We have a new meeting, or I guess you can call it leadership circle. Kelly, I know you went to the first meeting. So if you wanted to add to it, I heard it was really a great meeting.
Yeah, I did. I traveled out to that first meeting, and it was a lot of really new leaders in their up and coming companies. So there was a lot of questions. I was able to share more than anything, which I hope was helpful to some.
I heard it was actually. I had comments that you were very helpful. So thank you for going.
No, it was good. I mean, they had a fairly good turnout. It was in person. I believe tomorrow's is remote.
It is.
So hoping that they'll get more, because I think they expected more people to be in-person attendance, and not too many. I think it was a small group. I think there was maybe 15 of us. But a good group, they're eager to learn and share ideas and collaborate, which is great. So yeah, if anybody has any new programs or trying to grow, I think that it would be worth the while to at least get on the remote ones if they can't attend in person.
Thank you. Yeah, it's difficult to have an in-person meeting, and that was when was that, in January? Yeah. So I think it's going to be remote in person. And then just the blueprint for Oasis accuracy. This is the only one we're going to have this year, I believe. I'm going to be there. I have to keep up. I haven't been keeping up, and there's been a lot of changes. So I'm going to actually go to the class myself on March 12th and 13th. And if some people are questioning it, and I'm not just saying this, but I've been to some other ones, I always get something new, even though I've been to hundreds of them, not hundreds, I'm kidding. But I've been to so many. I always find something that would improve our scores, and I was able to take back to when I was on the road, what I could take back to my agency. So it really is a good program. And you don't have to take the exam on the 14th, but there is an exam, certification exam, if you would like. And that's in Mansfield, Mass, and the link is there.
Colleen, can I
Yeah.
put something out there? I'm going back to hospice and the HOPE trainings that people are,
Oops.
there's a buzz about.
Yeah.
I sat in on a Well Sky training that they did, I don't know, 3 or 4 weeks ago. And they're going to be putting out, it's not released yet, so you can't sign up yet, but either end of February or early March, they're doing it's not to get a certification, but they're giving you like certificates for attendance on really understanding the HOPE tool.
Yeah.
I think initially, I think the training is like $400, but the special is a $200, so it's 50% off for $200. I'm going to sit in on that. I don't know, who's on this group for hospice. It looks like it could be a really good education series. So not that I'm trying to promote one individual, but WellSky usually does a pretty good job with regulatory and trainings out there.
Yeah, Cynthia, are you still on the
Did
call?
we lose her? Or is it just me? Here we go.
No, are you still there? Cynthia? Oh, I was gonna say, I know.
Yeah, I'm here.
Oh, Cynthia, I don't mean to put you on the spot if this actually happened, but for that hope assessment that we were talking about that I said,
Right.
did we actually get a speaker for that yet?
We were planning on jumping in on for June, but we were working on the date and pricing.
Okay,
Hope assessment. I believe it's June. Yeah.
okay, thank you. That's good enough. Will you send me that information, Kelly? For
Yeah.
that hope training so I can keep up?
Sure.
Yeah, that would be great. That would be great. Thank you.
Anybody else? As always, discussion at the end, and I'm trying to think of, I had a couple of questions. So if people are on this call and they put a question in on our listserv, and I was on vacation, so I'm still plugging through. I haven't got through all my emails yet. If you had a question that was not answered, please feel free to speak up or put it in the chat. Or if anyone has any other type of question, you can this is an open group. No question is silly. There, as I said, there is just too much information to remember. I'm having a hard time myself keeping it up. I don't know how you guys are doing it. Is that all? So I hope, and I would like some feedback, so you can shoot me off an email. You could put it in the chat. Is this going to be, I hope, better? So what this replaced, this meeting, it replaced our clinical directors. I do an update and then we have a regular meeting, and this networking, and then I do a QI one in the same month, a couple of weeks later or so. And there's some difference in information, and I don't give all this information. I give the information that pertains to that group. But I just didn't, we have to look for some better efficiency of my time. So we thought about this, and I hope this was, and I put hospice at the end, not to pick on hospice. But I figured there might not be as many hospice members. Maybe I'll put it at the top and then they don't have to listen to the whole thing. Let me see. Oh, they're looking at so in the handout is the link for the emergency. I think I did. Hold on. Did I put the link for the emergency? Yeah. So Cynthia put the link for this handout at the very beginning of the chat.
Actually,
And-
I tried, but I promise everyone will get the copy
Oh, you
of
didn't do
this.
it. Oh, okay. Oh,
It wouldn't, for some reason, it wouldn't upload it. I don't understand why, but I promise everyone will get a copy of the handout, and it will have all the links, etc., that you are looking for.
Oh, perfect. Perfect. Thank you. Oops, I have one more
Just
chat.
have a quick question.
Yeah.
Will this be the meeting where everybody will talk about their DPH surveys, or is that going to happen in a more like quarterly based meeting?
You know what? I forgot.
Oh, okay.
I forgot. We can ask. I was trying to put, there was so much information, and I was getting confused, and I did say to myself, everyone needs that information. I'm going to put that on, and I forgot. So I am going to, actually, has anyone on this call had a DPH survey recently? I'm going to look at my notes. A couple of agencies I know have, and again, we talk about this all the time, but they are comparing, I think this is from CMS, right? Are you giving the patients the services that they need? And then why aren't you? So the DPH surveys probably for the past few months have been focusing on your actual visit frequency that you provided and what was written and what was the excuse for not going. And if it was significant, notifying the doctor. So that has been a couple of agencies. Another agency, there was issue, and I see this is all that same thing with this acceptance of service policy. And it's not just the acceptance, meaning, and then you can provide the services. So it's kind of a focus. So recently an agency had an issue with not getting in within 48 hours. So you have to remember that. And you know, it can't be for your convenience. If you get a start of care date, maybe the patient said, oh, I don't want you in 48 hours. And, you know, you call the doctor and you say to the doctor, she's refusing. Should we continue? What should I do? And if the doctor gives you a new start of care date and says it's appropriate, you know, like documentation like that. But I think, you know, and with scheduling and all that, you see how documentation doesn't get in the chart. So maybe just focusing on how you document or who puts it in. You know, it doesn't necessarily, it could be maybe your scheduler pass the information on to the clinician and that's in the record or something. But I just wanted you to know that that was an issue. And what else? You know, still looking at regular charts, but those were the few things. Let me just look one more thing. But I will put it on. Thank you, Melanie, for pointing that out. I did forget. Anything else on this that I forgot that kind of standard that we usually do? Let me know if you can't think of it off the top of your head. Okay, I think that's it. Anybody else have any questions before we sign off? Okay. Have a good day, everyone. Thank you for signing on, and I see you soon.
Thanks,
Thank
Colleen.
you.
Thank you, Colleen.